Good afternoon and welcome to today's Calderdale and Kirklees Joint Health Scrutiny Committee. I'll remind members that the meeting is being webcast live. Can I ask members of the committee to introduce themselves?
Councillor Colin Hutchinson from Calderdale. I'm co-chair of this committee.
Councillor Jackie Ramsey, Dewsbury South, and I'm the chair of the Health and Adult Social Care Scrutiny Committee in Kirklees.
Howard Blackburn, councillor for Calderdale. I'm the chair of the Adults Health and Social Care in Calderdale itself. Thank you.
Mike Barnes, representing Calderdale, and I'm the deputy chair of the Adult Health in Calderdale.
Councillor Alex Lukic, councillor for Dewsbury East Ward in Kirklees.
And on Teams we've got Councillor Munro. Councillor Munro, do you want to introduce yourself, please?
Thank you. Hello. Yes, I'm Councillor Munro, and I'm sitting on this committee. Thank you.
Thank you. And I'm Councillor Liz Smage, and I'm from Kirklees, and I'm co-chair of the panel, along with Councillor Hutchinson. Right, let's move to the agenda then. Minutes of the previous meeting. These minutes are from the 16th of November. So if we just go through them then. So page 1, anything on there? Page 2, the second bullet point, we did say at that point in time that it was critical that the Scrutiny Board receive the outline business case as well as the full business case, so as to ensure that health services were delivering for residents of Calderdale and Kirklees. Anything else on that page 2? On Colin?
There was also in the 5th bullet point, officers advised that they could provide a profile of capital spend going forward. I'm not aware that that's been brought to us.
On page 3, third bullet point down, we asked for the social value action plan to be provided. The next bullet, we asked for a full detailed report on how the FBC addressed compliance with best practice and supporting local and regional system of affordability. And then a bit further down, we asked for positive impacts identified and detrimental impacts. We then talked about financial sustainability as well. Are there any other points on those on that page? No. Page 4. Any points on page 4? Councillor.
It does state here that members agreed to explore the possibility of the board having a direct working relationship with the construction company. I don't think that's been taken forward.
Okay, thank you. Page 5, page 6, page 7. Okay, and I remind members of the committee that we also said we would like to meet with the ambulance service, revisit the travel plan and revisit the carbon budget, and the ambulance service modelling is on today's agenda. Okay, thank you. Do we agree those minutes from that meeting? Thank you very much. Okay then, are there any interests that anybody wishes to declare at this time? No. If there are any that come up during the agenda, just please let us know and fill in the appropriate form. All the debates in the meeting are in public today. For deputations and petitions then, we've got 2 deputations. Jenny, if you want to give yours first, if you want to say who you're representing, and you have the usual 5 minutes, Jenny. Thank you.
Oh, okay, thank you. I'm Jenny Shepherd, and I am basically representing 80 plus members of the public who signed an open letter to this committee in early September asking it to urgently meet in public. And I think all the members of the Scrutiny Committee should have had this letter, because I did send it to all of you, and I can't remember if I sent it to the scrutiny officers. So this is my deputation. The committee must now please declare its deadline for informing the Health Secretary whether it can or not confirm that CHFT's business cases meet the 3 criteria required for his approval of the revised plans. As things stand, they don't seem to meet concerns about the safe capacity of the reconfigured hospital services, but CHFT is rushing ahead with the reconfiguration. The Scrutiny Committee and the Secretary of State need to make their judgments on the business cases before CHFT puts contracts out to tender. The Joint Scrutiny Committee cannot allow unsafe hospitals to be built, and it has the statutory power to stop this happening. So, Scrutiny Committee, please answer these 6 questions today. 1. Do you have a deadline for letting the Secretary of State know if his 3 criteria for approving the revised business cases have been met?
We will pause the meeting, as no doubt you can hear. Hello again,
Andrew.
and we apologise for the interruption. We just had a fire alarm, but it turned out to be a false alarm, thankfully. So, Jenny, you were in the middle of your deputation. If you want to start off from your 6 questions and carry on. Thank you.
Thanks. So, to the Scrutiny Committee, I say please answer these 6 questions today. 1, do you have a deadline for letting the Secretary of State know if his 3 criteria for approving the revised business cases have been met? 2, if so, when? 3, if not, how are you going to account to the Secretary of State for the fact that CHFT and the West Yorkshire Integrated Care Board, which is responsible for prioritising this capital investment, are barrelling ahead without the committee's approval or the Secretary of State's permission? Plus, will the co-chairs confirm whether, on the basis of DHS guidance on scrutiny, that in cases where information may be commercially sensitive, it may be possible for health scrutiny to receive this information in confidence, to inform but not be directly referred to in its reports and recommendations? So in the light of this guidance, have they received the business cases that CHFT refused to publish and present to the November 2021 scrutiny meeting? If so, did this take place at a private meeting in June 2022, and who was present at that meeting if it happened? We want to make sure that what replaces our 2 district general hospitals is safe for patients and staff and can safely accommodate everyone with a clinical need for hospital care. There is so far no evidence that this is the case. The Scrutiny Committee must urgently and conclusively establish whether the planned hospital beds capacity is safe or not. We will not stand for patients being turned away from the reconfigured CRH, told to stay at home and call 111, being held in ambulances outside A&E, in corridors, or sent to wards without the capacity to care for them. And this proposed reconfiguration can only lawfully go ahead if the Scrutiny Committee confirms to the Health Secretary that it meets this criteria. The NHS organisations have consistently evaded repeated requests from Scrutiny and the public for reliable data about whether the impact of the Care Closer to Home programme on emergency hospital admissions will mitigate the population increase. This information was not in the 2019 revised strategic outline case. It has not been publicly provided since then, despite repeated Scrutiny Committee requests and a massive FOI request from us. If CHFT does not provide the required answers today, councillors must surely tell them their time is up and announce an urgent deadline for referring the revised business cases to the Secretary of State. We have no wish to drag this out. We're fed up with coming to meetings after years and years and years, but the plans must not go ahead without evidence, sound evidence, that they will safely meet all patients' clinical needs. Thank you, that's it.
Thank you. I think some of your points directed at the committee will be addressed in items 6 and 9 of the agenda. Okay. Do you want to give Rosemary's?
Yes, please. Okay. So Rosemary's asked me to read this because okay. Yeah, okay, so this is Rosemary's. I'm asking CHFT to acknowledge that the public interest overrides commercial confidentiality and to immediately publish both current business cases. It admitted this in 2014 and 2017, so what's changed now? The public interest requires that the business cases include sound evidence that the reconfigured hospital's capacity can safely meet future needs for both acute and elective services. Does it? CHFT claims an FOI Act exemption from publishing the current business cases now because it will publish them once full approval has been received from NHS England and the Treasury and the tender process is completed. CHFT's excuse is that it has to maintain the confidentiality of information of, and I quote, high commercial and legal sensitivity so as not to compromise future public sector procurement processes, end quote. Have they forgotten that the business cases also need approval from the Joint Health Scrutiny Committee and the Health Secretary, and before the tender process? In 2014 and 2017, CHFT conceded that the original reconfiguration business cases were public documents. In 2014, after Councillors Tim Swift and I jointly asked CHFT to review its refusal on grounds of commercial confidentiality to publish the outline business case, the Trust agreed to provide a copy with commercially sensitive information redacted. And in 2017, the Hospitals Trust reported at the board, we have considered the potential future procurement risk associated with full publication of the full business case. However, we believe at this stage that the need for local people to know and scrutinise the detail of the business cases takes precedent. Therefore, we have made the FBC publicly available in its entirety without any form of redaction. The public interest overrode commercial confidentiality then, so why doesn't it now? In addition, CHFT must update the business cases to answer questions from councillors and the public 11 months ago and to take account of significant changes since the 2019 strategic outline case. The June 22 slides presented by CHFT today add nothing to what they said in November 2021. They ignore serious questions raised by councillors and the public 11 months ago. For example, the councillors asked CHFT to revise the capacity assumptions on the basis of the 2021 census because significant population growth has already occurred since the 2011 census. Has CHFT done this? Other significant changes since the 2019 strategic outline case that CHFT's business plans must account for include, first, the additional burden of ill health from long COVID and from a decade of austerity that's so great it significantly shrunk the economically active population. And second, the crisis in the NHS and evidence across England that this is related to the shift of services out of hospital onto desperately under-resourced GP practices, community health and social care services. Despite shifting services out of hospital, nearly all of them have unsafe levels of bed occupancy. This has been the case for years at Calderdale Royal Hospital, with Calderdale CCG frequently reporting that the hospital was running at unsafe occupancy levels over 90%. Do the business cases predict that the new acute and emergency hospital will run at these unsafe occupancy levels? And it's not just about the acute hospital's capacity. At least since 2016-17, CHFT staff shortages have meant that it's been unable to fully use its diagnostics and elective procedures facilities, so it's resorted to paying private companies to carry out elective procedures and diagnostics using CRH and HRI facilities. This so-called insourcing has increased since COVID hit. One insourcing company used by CHFT is a moonlighting Sheffield NHS consultants private company, Pioneer Healthcare, based at a US Aspen Healthcare-owned private hospital in Sheffield. The acquisitive company, Totally PLC, recently took over Pioneer Healthcare. But what's happening to Sheffield NHS patients while its consultants work for a private company that's been providing elective procedures to Calderdale and Huddersfield patients? How crazy is this? Does the outline business case account for the Trust's inability, I've got two short paragraphs, to provide the required volume of elective care and diagnostics even pre-COVID? Does it identify challenged specialities that currently depend on insourcing, such as ENT, ophthalmology and neurology? And how long will this continue? Does it include the predicted costs of insourcing, which the Trust has to bear itself as they are not reimbursed by the clinical commissioning groups and now the Integrated Care Board? We need this information about the safety and financial sustainability of the proposed reconfigured elective care hospital services. Thank you.
Thank you. Okay, thank you for those deputations. Are there any public questions at this time? Okay, thank you. We move to item 6 of the agenda. Councillor Lukic.
Thank you, Chair. Just on advice, although I don't think it directly relates to anything on today's agenda, I'm just happy to state for transparency that I am employed by NHS Digital.
Thank you. All right, so we move to agenda item 6. This is a report of the informal workshop that was held on the 22nd of June. The then members of the committee met with CHFT and went through a report on the summary of the issues that we had been asking about in relation to the OBC. So, on page 12 of the papers, it makes clear that Scrutiny does have a mechanism by which we can look at extremely commercially sensitive information. The mechanism that was agreed with CHFT at this point in time was that the co-chairs, Councillor Hutchinson and myself, would have access to the whole document, and a workshop would be held where colleagues from CHFT would give a detailed briefing to all members of the then committee. So I believe that we did have a slight change in May of some of the membership, but it was the membership as of June 2022. The terms of reference of this committee, as per the background information in the papers, state that the role and function of the Joint Committee includes confirmation that it will review the revised reconfiguration proposals to include reviewing the strategic outline case, the outline business case, the full business case, and assess the clinical and financial sustainability of the proposals. The referral from that went to the Secretary of State and the IRP's subsequent report highlighted 3 areas: out of hospital care, hospital capacity, and availability of capital. On the availability of capital, it was said that the West Yorkshire Integrated Care Board had identified the proposals for Calderdale and Huddersfield hospitals as its highest priority for capital expenditure, and the Joint Committee indicated its wish to monitor progress on the building works and budget spent on both sites. Members also expressed concerns about the high levels of inflation and the possible significant budget pressures. Members also expressed concern at the assumptions underlying the workforce model, particularly for clinical staff. And members also wanted to ensure that all aspects of the new hospital buildings took account of the climate emergency. On capacity in hospitals at item 3, the revised proposals from the then CCGs had reinstated beds so that the number of beds not reduced in the current proposal, but the distribution across the 2 sites was changed slightly. Members continue to require evidence that the plan for maintaining the current broad number of beds is adequate for the long-term nature of the reconfiguration project. We also asked about activity growth assumptions, and that we wanted to scrutinise available sources of evidence in relation to the activity growth. Members also are aware that lessons learnt during the pandemic have meant that the design plan for both hospitals have changed, which includes improving ventilation and building more single rooms. And we also asked about capacity in hospitals, not just being about buildings, but also about staff. We also asked about effective preventative actions, and we moved on to community services. So we also said about the performance of community health services, and that should be scrutinised predominantly by the local scrutiny committees in each of the council areas. However, the impact of community health services on suppressing demand was one of the 3 key issues that the Secretary of State had raised with the then CCGs in 2018. So the Joint Committee reserves the right to consider the adequacy of community services in the planning of hospital provisions while relying on each local overview and scrutiny committee in both Calderdale and Kirklees councils to examine the evidence and report their findings. Okay, I hope that's clear. Does anybody have any points they wish to raise? Councillor Hutchinson, do you have anything that you wanted to say to that?
I think all along we have had concerns about the adequacy of the hospital estate to accommodate the work that's required for the health of the people of Calderdale and Kirklees. And we continue to have concerns that simply saying there won't be a reduction in beds is sufficient. The Health Foundation's recent report suggested across the country the changes in demographics and the number of hospital beds that have been removed over the last 10, 20 years has led to a situation that they model that 30,000 more beds are required across the country than there are currently. And I do think that on the basis of those concerns and the fact that Trust Board papers suggest that there hasn't been a slackening off of demand for the hospital beds within the Trust, so they've not been able to reduce the number of effective beds during the summer as would normally occur, that this must suggest that the system is running very hot indeed at the moment. And that is why I think it's essential that each of the local scrutiny committees reassure themselves that the capacity of out-of-hospital care has been increased enough to meet the modelling that is detailed in the strategic outline case.
Okay, thank you, Councillor Blackburn.
Thank you, Chair. I was consulted in relation to the outline business case as the Chair of the Adults Health and Social Care in Calderdale, and I'm extremely satisfied that actually I can't think of two more competent and thorough people to go through that document. So I'm satisfied in relation to that. So my question comes in relation to the funding and my concerns about the £197 million, whether it's actually going to go far enough at this stage, given the costs, the rising costs of materials, etc. So wanting some assurances that actually we are still on track and you have some contingency in place. Thank you, Chair.
Councillor Ramsey.
Thank you. It was just to highlight, I thought you covered it quite well, Colin, in your summing up, that it's the whole of the out-of-hospital care that's required, whereas we seem to have focused on healthcare rather than adult social care as well. So just to highlight.
Are there any other points on that paper, Councillor Barnes?
Thank you, Chair. I think my concern is to avoid a silo mentality within this. It's not our responsibility, it's somebody else's responsibility. It's not our problem, that's going to be picked up by primary care network. And I think this should be a joined up approach from start through to finish, and I think I'm not really seeing that. I'm seeing a we're okay, Jack approach at times. Thank you, Chair.
Thank you. Councillor Munro, did you have a point on this?
Yes, thank you. I just wanted to come in on the back of my colleague Jackie Ramsey's point about the whole, including adult health and social care, but also I'd like to make sure that the volunteer and community organisations, that sector as well, would that come under scrutiny? Because, you know, with the cost of living crisis, a lot of possibly volunteers, you know, they will be hit with high costs of transport and fuel prices, etc. So travelling, you know, to places to actually care for people will affect them even more so. So I just wanted to make sure that, you know, they're also included as well.
Okay, thank you. Maybe the transport point we can pick up under the yes. But Councillor Ramsey, you want to come in?
Yes, just to highlight, last week at Health and Adult Social Care Scrutiny in Kirklees, there were 100 patients that were medically stable in the hospital that weren't able to be discharged at that moment in time. So clearly that is having an impact on hospital care. So I'm just trying to emphasise that. I don't think there are any easy solutions, because clearly what we're getting as a message in Scrutiny is that workforce is the big issue, really, across the board. And the ability to recruit, not just in hospital, but out in community and social care settings is very challenging. And so capacity has to be looked at through that lens for me. I should know, but I've forgotten what the bed utilisation level is that's been modelled and what it is at the moment. And at some stage, if somebody could just remind me of that, that would be very helpful.
Yeah, we'll pick that up in the next item. Maybe the Trust can talk to that in the next item as well. Councillor Hutchinson.
As we know, as Councillor Ramsey said, workforce issues are the key factor really that's driving a lot of these changes. There has been a recent staff survey done, because retention of staff is important, that I believe does cast some light on the factors that are contributing to staff shortages within the Trust. And I would be interested to hear from the Trust as to what measures they are introducing and how effective they're proving to try and retain staff, which is just as important as recruiting.
So can we ask the Trust in the next item, when you're picking up about the different models, etc., that you could pick up some of these questions as well? Okay, because I think we ought to get on to those items if we can. But do we want to record as well that we did see the full OBC, and I think we didn't see anything that raised extra concerns. There was no surprises, but it hasn't altered the areas of concern. Councillor Hutchinson.
And I would also say that this business case was principally for the work being carried out at the Calderdale Royal Hospital site, rather than the full business case for the Huddersfield Royal Infirmary development.
So we just need to clarify, we haven't seen the full business case for the HRI development, and we haven't seen the full business case for the reconfiguration. Okay, I will do, yeah. Okay then, so on this item then, maybe we could ask from this scrutiny committee, we could ask the scrutiny committees in Calderdale and Kirklees to look at the capacity in community services in detail and report back, so we get the reports back to this committee, and then we have some clarification as to capacity in community services. Do you feel that would be something we could recommend?
I absolutely recommend that, yeah, fully support.
Agreed with everybody, yes? Thank you ever so much, everybody. Right, if we can then move to item 7, the update on progress of the new HRI Accident and Emergency Department. We have with us today, when I can find my piece of paper, we've got Anna Basford, Mark Davis and Stuart Barron from CHFT. We do need to say that we invited representatives of the Integrated Care Board here to today's meeting, but they were unable, disappointingly, they were unable to make the meeting here today. Anna, do you want to start? Thank you.
Thank you very much for the opportunity to provide an update around the development of the new Accident and Emergency Department. As you said, all three of us as colleagues from the Trust will present to that. We've sent through a set of slides which I hope are just about to come up on screen. And Mark Davies will introduce himself as he starts off. We'll start the presentation and hand over to myself and to my colleague Stuart Barron.
Thank you, Anna. My name is Mark Davis. I'm a consultant in emergency medicine and clinical lead for reconfiguration and transformation at CHFT. And I have the pleasure of chairing the project board that's overseeing the build and delivery of the new A&E at HRI. So I'll take you through where we're up to. So just to remind people, we're building a new A&E at Huddersfield Royal. It's in a slightly different place to the current A&E. It's on South Drive, which is the other side of the hospital, which allows us to continue delivering A&E services from the current A&E while it's being built. It'll have dedicated access from Acre Street with signage adequately supplied, and there'll also be access up for ambulances from Occupation Road at the other side. There'll be dedicated patient parking and drop-off areas outside the building. The building itself will enable us to deliver the care that we're providing currently to the patients of Huddersfield who self-present and come by ambulance, but with dedicated resuscitation, majors, minors, and a specific paediatric area, which we don't have currently, so children can be kept completely separate from adults, and it'll have an integrated X-ray facility embedded within it. The design is aimed to be state-of-the-art. This is an artist's impression of what a clinical assessment room will look like. And I don't know if anybody's been to Huddersfield Royal recently, but you'll see that this is significantly different to what we've got currently in terms of fit for purpose in a 21st century healthcare environment. The glass doors on the cubicles will allow for visibility, but privacy and dignity when required, and will improve things like infection control within the department. And it's been designed with flexibility in mind so that if there was a future pandemic, it wouldn't have such a big impact on how we deliver services. So where have we got to? Well, back this time last year, this was where we're building the department now. There are a couple of doctors' residences as were, but are no longer used. I personally lived in one of these for 6 months back in 1995 as a junior doctor. But there was no tear in my eye because it's the right thing to do. So we demolished those, and then back in December, late December, after we got approval of the full business case, we started work on groundworks. And for a number of months, it looked like we were just moving piles of earth from one place to another. But in fact, they were doing an awful lot of drainage, foundations, and all the groundworks that are required. And then towards the spring, we started to see an outline of the building. And then in June, the floor slab was complete, which gives us an idea of the size of the building, which is about 50% bigger than the current A&E footprint at Huddersfield Royal. From there, the steelwork went up in July, followed by some sort of a floor that goes on top of the roof that staff can walk on, but won't be for patients. And the other little block of steel on top, that's for the plant room, because this is all a single-storey building. And you'll see the wooden boxes there, skylights, that are in place so we can get natural light down into the middle of the building as well. Back in August, started to put the exterior walls on. The stonework will come later, and that's effectively just a facade. This steel and insulation that's there currently is effectively making the walls watertight. And as we move on, that means we can start fitting the inside. So we're already starting to build partition walls in the middle, and that will be going on until about December, when the mainstay of the internal structure of the building will be completed. Moving from here, like I say, the partitions will be complete by about December, and then over the following few months, there will be progress made on the internal fit-out, as well as landscaping in the spring next year around the building, so that they'll be ready to test and commission all of the services that will be in there, and plan to hand it over in July next year, and we will be operational, seeing the first patients in August. We're just in the process of signing off an interior design strategy, which has been inspired by the waterways and canals of Huddersfield. So the colours of each of the different areas are designed to be dementia friendly and improve wayfinding, so patients can find their way based on the colour of the walls. It's taken account of those with visual impairment, aggression reduction, and there'll be bespoke paintwork and furnitures for bereavement and children's areas, so recognising that they need to be slightly different. So again, artist's impression of the type of what it's likely to look like, and again, for those who've been previously, is significantly different to what we've got now. Again, it's a purpose-built environment which looks like somewhere where you'd like to work and like to be looked after. The children's area, like I say, will have a bespoke decor, which will help with distraction therapies and things like that. Again, this is an artist's impression, so it's not going to be just like this, but this is the type of thing that we're looking at, and with dedicated seating areas for children, again, away from adults. In terms of governance of the project, there's a project board, which, like I say, I chair, which sits once a month, and that reports into the Trust Transformation Board and subsequently into the Trust Board itself from an oversight perspective, and keeps an eye on financial position of the project. And we have regular reports from a project manager who's employed separately from the construction company, a site supervisor who's employed separately from the construction company, as well as myself and our infection control colleagues. We have fortnightly visits to sites so we can see it for ourselves, what's going on. And there are bi-weekly meetings with all those parties who are relevant to the bill to make sure we've all got oversight of what's happening. And to date, there have been no significant issues identified from any of the supervisor or building control visits. All the planning conditions have been met to date. There's a couple that are in progress and we'll be there by the time we get to the point of no concerns identified. We're on target to BREEAM Excellent, with 56 of the 70 targets credits that we require already attained and are projected to get to 76, so we're not concerned about that at the moment. And we're on track from a timescale perspective to complete in July 2023. As well as building the building, we're also conscious that there'll need to be some changes with how we function within it and how we make sure we maximise that the benefits and operational deliverability of service that we'll have in the new building. And the Emergency Department operational leadership team are overseeing that. And they've got dedicated senior clinicians, so there's another consultant within emergency medicine who's responsible for making sure that's going to deliver what it needs to deliver from a transformational perspective, and that we don't just do exactly the same as we're doing in this new building. And they're working with colleagues across the whole of the organisation in terms of reviewing the workforce model, and is this an opportunity to change the workforce model to be more efficient, and as well as that, looking at clinical pathways in and out. It's become almost a catalyst for some of the changes that we thought of doing in the past, and it becomes a good reason to get on and make those changes, and we've got the capacity in to make those changes as well. There's a high-level transition plan being created in terms of how exactly are we going to move from one department to another, because it's a big upheaval, and that will include significant communication both within the department and the organisation itself, but also with colleagues, with external stakeholders, the general public, because what we don't want is on day one that we open, half the population of Huddersfield coming just to have a look. But we need to make sure that they've had sight of it, and we will make sure that there's plenty of information out there in the public, pictures, video fly-throughs, so that everybody's aware. And I'm sure at some point between now and then I'll be able to come back and give you more information on that. And as well, the other bit that we're going to do, while it's not quite ready to take patients, we will do a lot of simulation training in there to make sure that everything's exactly where it needs to be. I mentioned earlier about social value. So we've got an agreed social value plan that our construction partner IHP has delivered, and that gives examples of things like apprenticeships using local businesses. So for example, those partition walls we were talking about earlier, they're being created by a company that's based in Cleckheaton. We've used quarries from Shepley. The mechanical engineering is going to be produced by Clifford Cooper, which is based in Elland. So there's a significant proportion of the labour and the materials coming from locally. The stones on the outside, the Yorkshire stone on the outside of the building is coming from Myers Quarry. So over 70% of the cost to date has gone into the local economy. And as well as that, simple things like the construction team, a few of them went and did a litter pick on Lindley just to help out the local community, recognising it is a bit of disruption to the local area. And 3 of them walked the 3 peaks for the Trust's charity. Equality impact and quality impact assessment is ongoing for the whole of the reconfiguration project. We did a big exercise last year where we looked at a number of groups of those with specific characteristics to make sure that there weren't any missed impacts that we weren't aware of, and there were no significant impacts identified that weren't being mitigated. And that will be an ongoing program that we'll do throughout the whole of the reconfiguration to make sure that we continue to have the positive impacts that we expect and no unexpected negative impacts. I'll hand over to Anna.
Okay, thank you very much. I know that part of the question was that we would talk about our availability of capital and how we're using funding for wider investment in Huddersfield, and also the point that was raised by Councillor Blagborough regarding inflation and contingency. So this joining slide is just to remind colleagues that the allocation of funding was made following our response to the recommendations of the Independent Reconfiguration Panel in 2018. And we described the modified plans within the strategic outline case that was then published in 2019. And our plans remain consistent with that strategic outline case. So I'll hand over to my colleague Stuart, who will introduce himself and just talk through how we're using that capital investment at the Huddersfield site.
Good afternoon, everyone. I'm Stuart Barron. I'm Associate Director of Finance with the Trust, and I work with Anna and Mark on the reconfiguration programme. So I'm just going to pick up a couple of points that were raised outside of the committee with a couple of slides. The first one was around the capital investment that's gone into the HRI site to date. And what I've listed in the slide deck there is over £20 million worth of investment that's gone into the HRI footprint already to date. So Mark has shown you the images of the new HRI Accident and Emergency Department, and that's costing £15 million. We have also done a ward upgrade, so converting more to single rooms, which is more aligned to modern healthcare facilities now, and that took place in 2020 and was at a cost of around £4 million. We've done some work around our changing facilities, so make sure that there's a suitable environment for colleagues to get changed so that they're appropriately dressed for work and not leaving work with uniforms on, etc. From an infection control perspective, it's a nicer environment now. We've also significantly changed the site through demolition of a old learning centre and old nursing residential that was at the bottom end of the existing HRI site, and re-provided that in 2021. And that creates a facility for learning provision for the hospital to make sure that we keep everyone's training up to date, etc. We've also spent money fitting out retail catering facilities, and that's been a real success. There's an image on the slide there as well that you can see. But again, that talks to some of our local agenda as well. So we're using local products and local supply, home-cooked food, making sure that colleagues have access to nutritional food for during the work, but also for patients and for visitors on there. And we continue to do some of our backlog maintenance, so that the site does have a significant amount of backlog maintenance on there, and we continue to invest in doing that. So our building management system, ventilation, and moving that forward, and as part of some of the learning from COVID, emergency lighting, generators, fire compartmentation, asbestos removal, as the site's got some challenges with asbestos. So I've outlined just a few of the investments made over the last couple of years, but as I said, that's just over £20 million that's gone into date. On the next slide, we've got some future investment plans. So there was a question around what our continued investment into that site looks like. So these will be over the next few years, and some of these are enabled through the reconfiguration. So some of it can't take place until we've reconfigured the site as set out in our plans. But it continues a ward refurbishment programme. So again, modernising some of our estate facilities that haven't seen significant refurbishment programmes since it was built in the 1960s. There's a theatre refurbishment, so again, the site under reconfiguration will be a planned care site, which will mean all our elective activity runs through there, so it will need modern facilities for theatres, and we'll do a theatre refurbishment programme to allow that. There's two programmes closely linked, so the window replacement and cladding solution. So we do have a challenge, and those that have been on site will see that we do have a cladding challenge that we're managing annually through inspection. Some of the Portland stone have had challenges of movement due to poor weather and the age of those, and we've got a solution to manage that risk at the moment, but that will be addressed when we reconfigure and we can get access to the whole of the estate as some of that becomes free. And then there's fire compartmentation, so this is just making sure that if we've got a 30-minute compartmentation in place or a 60-minute compartmentation, should the unfortunate event of a fire take place, then we can make sure that colleagues are safe and the patients are safe, and we can have a fire strategy that is surrounded by that compartmentation. We do continue to address asbestos, so that there are some challenges of asbestos on site, and we have to remove some of that each year annually to make sure that when we try to do some of these programs like water refurbishments, that doesn't get in the way of the progress with those. And then the site rationalisation. So I've described the nurses' residential and learning centre being demolished, and Mark's shown images of the old houses that were on there in Savile Court. So we continue to rationalise that site so it's fit for purpose going forward. There was a question then raised ahead around cost management, and this is sort of the point that was raised earlier on about how we are managing cost going forward. So our OBC demonstrated affordability of the programme, so the reconfiguration programme we've set out, our OBC business case demonstrated that overall affordability and was priced in 2021, so capturing some of those inflation factors that have been going on over the last 12 months to 2 years. We do have a significant allowance for inflation, optimism bias within our capital envelope, so in reviewing our business case, NHSEI and Department of Health look for, is there appropriate allowance for optimism for inflation? And that stands at over £40 million in our business case, and that, when it was tested in that review by NHSEI and Department of Health, was deemed sufficient.
Sorry, was that 14?
40, 40.
40, thank you.
Yes. And the work that we've been doing over the past 12 months in getting to design is validating that estate. So since moving from our strategic outline case to our outline business case, we've validated some of our activity data and made sure that we've right-sized that building going forward, and that ensures that we don't build a building too big or too small. We do refresh the costings as outlined in there, and that's planned again for November 2022. So this is about using our cost advisors, market intelligence, working with colleagues like at IHPU to see what the prices are on the ground, and testing those and making sure that they're still up to date and affordable. And we're undertaking feasibility studies, so there is work planned to the existing Calderdale building as part of the reconfiguration, and making sure that the two buildings work alongside as one building. And we're just doing some feasibility studies to get them detailed costed and in a way that we can procure them going forward. And then what we have seen significant benefit from is procurement. So when we did our outline business case, the design fees that we have commissioned were cheaper than we had allowed at our strategic outline case, because we went through that procurement allowance. That allows us to keep that contingency that I referenced in situ and available. And then last slide I've just put up there is just to leave you with some of the lovely imagery that we've got of our reconfiguration programme. So Mark's talked through the Accident and Emergency Department, the top left of that image. The right top is the new learning centre planned at Calderdale. The existing learning centre is a 1960s building. It's being built upon the top, so it will be demolished going forward. And we're re-providing that to make sure that we've got state-of-the-art facilities for education and training going forward. And that's planned in the top right. The bottom left is the associated development for the multi-storey car park, to make sure there's appropriate car park facilities on site at Calderdale to accommodate people's needs when they're coming to visit the site, whether that be patients or colleagues. And the bottom right is one of the images that we have of the new ward block and accident and emergency department at Calderdale in the bottom right. So you can see the ambulance access there. So the building to the left of that, as it's designed at the moment, is the A&E, the new A&E. And then the right is the additional ward capacity that we've described. Okay, that's me. Thank you.
Thank you very much. Just before I open it to questions, can you just confirm, I think colleagues may be interested in learning that the 20 million investment in HRI, the emergency department in HRI, that is within the envelope that you were expecting to spend of the total capital that you were allocated. And is that total capital that were allocated, is it still allocated, that total figure?
Yes, so the A&E department has got a cost of around £50 million for that. That is in line with what we expected and is in line with that, within that overall £20 million envelope that I described. What I've also just run through is some of the additional other investments that we've done through either the Trust internal resource or other sources of funding to demonstrate additional investment in the site going forward. From a total affordable envelope, the money that was awarded back in 2018 that Anna referenced before, that remains committed to the organisation, subject to going through its approvals of its business cases, the OBC and FBC, etc. So, and that's what where we remain at the moment.
I'll open it up to questions. Councillor Barnes.
So just for clarity, so the 15 million is out of the 197 million, okay? Because you were very keen to reference it was on time to hit, but there was no mention of whether it was on budget to hit that figure. So I think that was quite a big gap. Are you on budget to be within the 15 million?
Yes.
Councillor Lukic.
Thank you, Chair. Yeah, just to pick up a bit more on the budgetary side. So you mentioned, I think prices were 2021 prices. Can we be a bit more specific about when in 2021? Because that could either be a year ago or nearly 2 years ago at the moment. So it just helps us to understand a bit more about the amount of optimism and inflation difference there might be now compared to back then, with that refresh of costings coming next month.
Yes, certainly. So the outline business case that we've recently developed was costed at August 2021, so just over 12 months ago, and builds in inflation with the intention that you know you're going to build it in a few years' time, and that was the value that I referenced before as well.
Supplementary, no, you're okay. Councillor Hutchinson.
Thank you, Chair. In terms of the staging of this project, obviously when work begins on the Calderdale Royal site on the clinical build, I'm assuming that that will have an impact on the accident and emergency provision on the Calderdale site. But by that time, the new A&E will be complete on the Huddersfield site. What arrangements are you coming to for decanting work across the two sites?
So when we chose the site, part of the choosing of the site of the new clinical A&E and the ward base at Calderdale, one of the requirements was that the A&E at Calderdale continues to function while that's happening, because we don't have anywhere to take it. Yeah, so there's no plans to interrupt the activity at Calderdale A&E while the new A&E is being built there.
Thank you. And I would wonder if you could say a little bit more about what you were saying about the workforce model being changed to increase efficiency. And also, given that this isn't going to be the primary paediatric accident and emergency facility, what kind of staffing arrangements are you planning long term for the paediatric part of the Huddersfield accident and emergency?
So there's a couple of things that will be changing in terms of the workforce model at Huddersfield, both in time for August when we open, and then subsequently again as part of that catalyst for change. So there will be a dedicated children's trained nurse in that paediatric area of the department, and that's one of the things that we can't do now because we can't completely separate children out. So we can have a dedicated children's nurse in there. Other changes that we're looking at is, for example, at the moment we employ healthcare support workers to help feed patients and do non-qualified nurse tasks with patients like changing them, keeping them comfortable. And then we employ a porter to push a trolley to the ward. What we're looking at doing is a joint role so that the person who looks after them in the department can also push them to the ward. So there's continuity, you don't have to wait for somebody else to arrive. So it's just amalgamating some of the roles that are there, that are, again, are some of the things that we've thought about and talked about for some time, but this is the, right, now is the time to do it. So it's not significantly changing the workforce model, but it's making it as efficient as we can do.
Councillor Ramsey.
Thank you. Just a couple of questions, please. We talked about the contingency, or you talked about the contingency and the opportunity to revise where we are in November. Can I just ask, when did you last revise and what percentage of the contingency had gone then? Because what percentage are we expecting to go now? I am coming back with another one.
Okay, thanks. One at once is helpful. Help me remember. So the costs were last reviewed back in March this year, and you have to go through significant changes to make it do it. So what we've been doing at the moment, with Mark's been leading this with our ops teams, is making sure that we've got the interior design of the new Calderdale building, A&E and board block appropriate. And once we've done that and we've got the footprint of that shaped, then that's a significant stage for us to recost that. And it's very much driven at the moment by square metre rates. So that's what the market will say and say. To build a building of a healthcare standard and quality, it will cost X thousand pounds per square metre. And what we're looking at is whether it's within the overall affordable envelope, which we confirmed it was when we did it last time, and whether there is we protect that contingency as part of that and making sure that the allowances are there. So I don't have the answer off the top of my head what the contingencies movements were.
Okay, I think we're all of the same view that as prices rise, then the contingency will be utilised. And I was just trying to get a feel of at what rate, but perhaps what you're saying is wait until you review in November. Is that what you're saying?
I think so. I was just going to come in and just say yes, because we will do cost assessment throughout the project, and are we on track? But the key test are at stages of procurement and whether we can guarantee prices at procurement stages, which will give the absolute. So it's an ongoing process of us being able to forecast how we think the market might move and may impact for us from the best intelligence available to us. And we have expert specialist advisors supporting us in that work.
Thank you. Can I just go back to the transformation and the workforce changes? So it's good to hear that there's going to be a dedicated paediatric nurse. And I have to say, I do think the pictures of the A&E department mean that staff morale and patient morale is bound to be better going through that department. So, interesting that you're going to do a joint post between porter and healthcare support worker. That's interesting. I just wondered overall, is it, when you talk about efficient, is it going to be a cheaper workforce that are actually within that A&E department? Is that where we're aiming, or are we aiming? I'll just ask that. And what are the key elements that you're looking for around transformation so that we get a feel of that? Because we know at the moment there are ambulance waits, there are trolley waits, there are such. So it's just, if you can give us something tangible there, that would be helpful.
So in terms of the first question, in terms of the workforce, what we're looking at is making the most of what we've got. So we're not necessarily planning for a cheaper workforce, but making sure that the workforce model we've got is as efficient as it can be. So we're aiming to get all members of qualified staff working at the top of their licence, so that we've not got, for example, me changing a bed. Not that I've got any problem with changing a bed, but it's not necessarily the best use of my time. So that's what the workforce model is aimed to deliver. In terms of transformation, we're looking at things like increased streaming of patients from the front door, effectively, or from first contact with a clinician to places like the medical SDEC, the surgical SDEC, so that somebody who comes in who clearly needs to be under the care or investigated by the medical team can go straight to the medical team, so they don't spend 4 or 5 hours in the emergency department and then go and see the medical team. That improves the patient experience because they're seeing the right clinician earlier, and also decongests the department, so you've got less likelihood of people waiting on trolleys or in ambulances, or ambulance trolleys waiting to get into the department.
Just so I make sure that I fully understand, so they'll be fast-tracked through to a surgical assessment or a medical assessment, that's what you're saying, is it?
Increasingly, yeah.
Okay, all right, yeah. Councillor Brown.
Thank you, Chair. Well, Kevin will be most impressed from Grand Designs that you've come in on time and on budget. Just coming back to the reserves, it seems an awful lot of money, £40 million for reserves in the first instance. So I'm relieved that you're happy to reserve to cover the costs, but equally concerned as well, if that makes sense. It's one of those things that actually we could have used this money for something else. What is the probability of there being some money left and being able to fund some other things at the hospitals?
So I think the important thing is that the contingencies that I've outlined are in line with expectations from Department of Health and HSEI, who review and test the appropriateness of that case. Because, and as the committee has alluded to, we know that we're not building this tomorrow, we're building it in a few years' time, all being well. So we have to protect that, we have to protect that for inflation. I'd like to say that there'd be some money left at the end of it, but at the end of the project, if there are things that there is money left in it, it will go into patient care. So we will make sure that we've got the equipment that we need, the chairs and the facilities, etc., etc. So it's capital money, so it's ring-fenced for that programme, and we have to report that back to the Department of Health and HSEI as well as part of that process. So it's ring-kept money and will end up being spent on this project.
Councillor Bell.
Yeah, I'm sorry to go back to the workforce question, but I'm not sure I'm entirely satisfied with some what I'm hearing. Not necessarily is not a definitive no. And so are we going to see a reduction in headcount from the staffing first? Secondly, you put on the slide a comment about the modelling of the workforce, and what you've talked about is quite a minor change. Fast-tracking people through to surgical is not a workforce amendment, that's a procedures and processes amendment, nothing to do with workforce of moving people through to the right department quickly. Part of this, and comments that we said beforehand, was about the modelling of staff. We're getting bits, we're just not seeing the whole picture here, and it goes back. So you've talked about a very minor change. You've said it's not necessarily be a cheaper option. I saw Anna say that wasn't a planning not when about headcount, so no reduction in headcount. Can we just have more on this staff remodelling that is going to make all these wonderful changes that your slide implied?
So yeah, I can certainly get you more detailed numbers of clinicians and nurses or whatever. I think it's important to remember that the development of the new A&E at Huddersfield is a small part of the whole reconfiguration and transformation programme that we're describing. We're describing, as well as building a new A&E at Huddersfield, building a new emergency care centre at Calderdale, which includes a paediatric emergency department, a paediatric assessment unit, a new medical SDEC, a surgical SDEC, all on one floor, as well as 12 wards. And by moving all of our acute services onto one site, that will even further increase our capacity to change the workforce, increase the streaming of patients to other departments, which, while may sound like a relatively small change, is a significant change for a significant group of patients whose current care is just delayed by being in the emergency department. And we can talk about that because that's part of the full reconfiguration. What I'm trying to describe here is what's happening from the new A&E, and ultimately we're going to be looking after the current A&E patients in a new fit state-of-the-art building. And we're going to do what we can to modify the workforce around those patients, but the big changes will happen when we do the full reconfiguration in a few years' time.
I hear your point, but that's going to have an impact on Calderdale when you do the big reconfiguration. Because if you get it wrong at Huddersfield and you carry it forward into Calderdale, it's getting it even larger. that error. So it does have an impact of getting this right, because this is the test, surely, for the full reconfiguration. Because if it works at Huddersfield, if it works at Huddersfield, and let's hope it does, then that model will surely be then adopted in Calderdale. Is that correct?
Yes, part of it will be adopted at Calderdale, yes,
okay.
Particularly in terms of the
so Huddersfield is a trial, in a certain way?
Yes, it is a trial, but it's limited trial because we don't have a huge area at present to send patients to a medical estate, because the medical estate at Huddersfield currently is not big enough to take as many patients as we would like it to take. And the same with the surgical estate. What we're describing is designing a new facility over at Calderdale, which is big enough, and then that enables more of this transformation that we're describing.
And I presume you're discussing this with the unions, all these changes?
All of the relative parties are involved in the changes.
Thank you.
Can I ask about your communication strategy? Because you talked about you don't want people arriving at the wrong places. So can we just clarify what the situation is currently, both at HRI and Calderdale, what it will be in August, and then what you're working towards as far as the emergency departments are concerned for the full when you move to the changes at Calderdale, so that we've got that full picture of where you are currently.
Okay. In terms of what patients go where, you mean? Okay. So at the moment, anybody can walk into either department. In terms of ambulances, we've got agreement with the Yorkshire Ambulance Service that currently anybody across Huddersfield or Halifax who's suffering potentially from a stroke, from a primary cardiac or respiratory problem, unwell children, and women with maternity problems are taken directly to Calderdale. And anybody from Huddersfield or Halifax calls an ambulance with a significant injury, abdominal pain, or major trauma are brought to Huddersfield. In August, exactly the same will happen. There's no plans to change the way where people go in August. We're only going to change when we've moved all of our acute services to Calderdale for our full reconfiguration.
Thank you. I just didn't want anybody being under the impression that they couldn't go at this moment in time. No. Okay, that's fine. Are there any more questions? Councillor Barnes.
Yeah, sorry, Chair, just come back on that. I think in terms of communication, I think I'd like to point out that the Trust have engaged with local residents in Calderdale in regard to the Learning Development Centre. They have engaged with councillors, and they have done a communication with those residents that most affected around that area, involving them, and they've involved them in the process. So I think we have to recognise, I think it would be important for us to recognise that. That's a very important step. They have listened to previous comments and concerns and potential criticisms, and have moved that on, and hopefully that will shape going forward any further communication with residents around both hospitals.
I think I was also wanting the wider population as well, but I take your point, absolutely, Councillor.
Thank you, Chair. I would like to say I'm really pleased that work has started. We've served on this committee for quite a number of years, so it's actually nice to actually see something that's actually taking place. So whilst we have asked you some very scrutinising questions and being your critical friend, actually it's positive that actually we're actually getting things done and achieved. So yeah, well done in that way.
Councillor Hutchins.
I think I know the answer to this question, but just for clarity for anyone who might be looking in, when we're talking about moving patients promptly out of accident and emergency to a medical assessment unit or surgical assessment unit, those would not be on the Huddersfield site, or would the surgical assessment unit be on the Huddersfield site for the time being? Or would they require ambulance transfer to Calderdale for both?
No, they're on the Huddersfield site. They're currently on the Huddersfield site, and they'll stay on the Huddersfield site until we've reconfigured. Yeah.
Okay, thank you. Any more questions on this particular item? No? Okay, so I think, and this possibly goes to the full reconfiguration, and we've talked about workforce models, etc. So I think we'd like to see the workforce model for the whole, as well as the HRI site. And in you said in November you were reviewing your costs, and also at procurement stages you would review your costs. So I think we would like an update after that review in November time, if we can. We appreciate procurement contracts and everything might mean that they will move again, the costs, but I think we'd like an update after that November meeting, yes. And we're also about your communication strategy for letting people know what's happening at the two hospitals. I think a little bit more in depth on that communication strategy would be very helpful as well. Have I missed any other points on that? Councillor Ramsey?
Just around bed utilisation, I know that you know that we need to just be assured that we understand the capacity and demand issues now and the capacity and demand issues going forward.
So bed utilisation, I think that's for the whole reconfiguration, is that, isn't it? Okay. And yeah, and can you just confirm for the HRI part of it, the full business case, you said you'd got approval for that. Is that still commercially confidential, that full business case?
That remains commercially confidential. It forms part of the wider outline business case.
So my question then will come on to the next part when we talk about the business cases for the full reconfiguration. Okay, because it's about how we see things that are commercially confidential to get the whole picture. Okay, I think that's probably where we might have questions. Right, thank you for that then. So we'll move on then to I've completed. Sorry, item 8. Yes. When just before we move on to that, when we're talking about the full reconfiguration, full business case, when will you have, what's the timetable for that going for approval? Because you mentioned about approvals, didn't you?
So the current stage that we're at is the outline business case for the reconfiguration has been approved by NHS England and Department of Health and submitted to Treasury. We're awaiting Treasury approval. On the back of that, we will then progress the next stage of work, will include us going through a procurement process to specify specific prices, and that's needed for us to then generate the full business case. So in terms of that, the timeline at the moment is subject to the timing of approval nationally. So, we do have a plan around that, which would put us at towards the end of 2023 that we'd planned for. But there is, you'll realise, there's been a period of uncertainty in decision making on timing. So we're just keeping an eye on that. So I don't want to name a month right now, but that's the sort of timeline we're working to.
Yeah, we appreciate that. We know that timescales do move around for approvals. Yeah, some of us have been doing this a long time, haven't we? And we know that timescales move around for approvals. Yeah, okay. All right. We'll move to item 8, the Yorkshire Ambulance Service revised modelling. And we have Andy Simpson from the Yorkshire Ambulance Service online for us today. Thank you for joining us, Andy. Do you want to give your presentation? Thank you. Do you need the presentation sharing, or are you just going to talk to it?
Would you like me to share it from where I am, or would you like to share it? I'll just go through the pertinent slides.
Either. It doesn't matter either. If you want control of your slides, do you want to share?
Yeah, I'll share it from this side.
Okay, thank you.
Just tell me when you can see that, please.
Yes, yeah, we can all see it. Thank you.
Just I think Mark's already talked through some of these, so he's already given the sort of purpose and aim of the actual modelling that we were asked to do for CHFT, and he gave us the arrangements that were going to be the high-end clinical model for CHFT in terms of where ambulances would go after the reorganisation of services. I suppose alongside that, we were also asked to look at what would be the potential impact of neighbouring EDs. So if Huddersfield is no longer available as the nearest ED, where would the next nearest ambulance be for some patients? Obviously, the majority of cases would go to Calderdale, but it would potentially impact on other EDs such as BRI, Pinderfields, Barnsley, which I'll talk through later. And obviously, the purpose was to inform the outline business case. So it's all based on a period of time a couple of years ago now. That basically goes through the chronology from Yorkshire Ambulance Services perspective. As you can see, it's been a long journey, starting from 2014, and it's also been subject to other demand reports, which are subsequently are now outdated. So this is the latest one that we completed in 2020. So this is perhaps the most important slide, is to go through the operational and quality impact assessment. So in terms of doing the report, what we were interested in looking at was the extended journey time. So if Huddersfield is not available to an ambulance crew, what is the next nearest emergency department, and what is the difference in time and mileage in terms of that journey, and also the return journey back to their own area. So that was one output of the report. It was also to understand the additional IFT activity, certainly based on his lessons learned from the Mid-Yorkshire reconfiguration of services. The IFT, I can probably safely say, was a little bit underestimated during that reconfiguration, and we certainly learned some lessons from that. So I've broken the IFT activity down into two portions. So it'll be when I say IFT, that's the transfers, interfacility transfers, pardon my acronyms. So this will be the patients that potentially will still walk into Huddersfield Royal Infirmary with conditions that will need to be treated at Calderdale Royal Hospital. A classic example being somebody walking in with cardiac chest pains. If they ring 999, that patient will be automatically conveyed to Calderdale or potentially Leeds General Infirmary if they fit the acute MI guidelines. But if a patient walks directly into Huddersfield Royal Infirmary, then they'll have to be transferred by ambulance to either Leeds or Calderdale. So we looked at that information, and we also wanted to look at potentially the movement of patients from Calderdale to Huddersfield Royal Infirmary. So these will be potentially patients that are step-down patients, low acuity patients from an ambulance service perspective, patients that have had their acute episode, been treated within Calderdale, and are now being conveyed back to Huddersfield in order for ongoing care and most likely discharged from there into home or social services. The methodology we looked at all 999 emergency conveyances between the dates specified there. We looked pre-pandemic from the point of view of the two pandemic years, completely overhauled everything we knew about ambulance demand. Everything was skewed. So the hypothesis was post-pandemic, we will go back to reasonable demand levels that we would recognise, which we have. So these figures were taken from pre-pandemic to make sure that they were as accurate as possible. All the 999 journeys were included, so every patient that arrived at Huddersfield Royal Infirmary, and we took into account patients that would have an extended journey, and we also took into account patients that would have a reduced journey, because as Mark's already alluded to, trauma patients go to Huddersfield, so may bypass Calderdale at this point, but in the future those patients would be closer, so they would have a reduced journey if they were going direct to Calderdale in terms of severe trauma. We all looked at the IFT demand, so this is where the collaborative approach took place with CHFT. So they supplied us with data from the same period pre-pandemic, and that provided us with data of all walk-in patients that had arrived at ED and that were subsequently needed admitting for further treating. The hypothesis being that once we go for full reconfiguration, those patients that have been admitted would need to be admitted at Calderdale and they would need an emergency ambulance transfer. We took all the interfacility data from the analysis to avoid any double counting, to make sure that the data was as robust as possible. And we used historical data for timings. Where we didn't have that, we simply used the AA route planner as a reference. That's a pretty much accepted tool for the ambulance service. So based on all that information, the two BI departments did their magic and came up with this output. So it references there 72 conveyances per day. This is not new activity. So the 59 patients a day, that's the patients that were conveyed to Huddersfield Royal Infirmary on a daily basis. Like I've said, that's not new activity, but potentially those patients may have an extended journey. Some would have a reduced journey, but overall it was an extended journey time. So that was calculated that in order to mitigate the impact, we would need to put an additional 10 hours and 39 minutes of ambulance time into our rosters to mitigate that extended journey time. Through the algorithms that they used, obviously a double crewed ambulance is 2 staff on that, so we looked at the staff time, and that equated to an additional 30 hours 26 minutes to be put into the rosters to mitigate the impact. All we could model was the acute transfers. We have not modelled the step down transfers. So the 13 interfacility transfers, this is new activity caused by the transformation of services. So this is the patients that have walked into HRI and need onward transfer because they need to be admitted at Calderdale Royal Hospital. So looking at the demand given to us by CHFT, we concluded that would mean there'd be 13 interfacility transfers per day of new activity. That equated to 29 hours, just under 30 hours, 29 hours, 57 minutes additional ambulance time required, and 85 hours per staff time per day to mitigate that impact. So that was to inform the outline business case, and I believe those figures are within the outline business case. This is the system impact we were asked to look at. So if Huddersfield Royal Infirmary ED was unavailable, where would the crew convey the patient to their next option? This is heavily caveated. Obviously, mileage and time distance is not the only 2 metrics that crews would take into clinical decision making of where the patient is conveyed to. There's an element of specialities available at various hospitals. There's an element of patient choice, and there's also an element of specialist facilities such as LGI in order to move severe trauma and cardiac patients. But this initial look at the system impact showed the following results. The biggest impact was obviously on Calderdale Royal Hospital, as expected. An additional 54 patients per day would be conveyed to Calderdale Royal Hospital. Barnsley District had the next highest impact, between 3 and 4 patients per day, 3.6 there, but more realistic, between 3 and 4 patients per day would be transferred to Barnsley District Hospital, most likely from the south part of the Huddersfield patch. Just looking at now at the figures that we outlined in terms of the outline business case. So in order to furnish those additional ambulance hours and the additional staff hours, we modelled that we would require 22 extra whole-time equivalents. That would be split into 11 Band 6 paramedics, 11 emergency care assistants, the additional management, the additional EOC in terms of call takers and dispatch, and the additional fleet that we would require, which we modelled at 3 additional double crewed ambulances. In there is also the training development and support of the paramedics and staff within there with his partner organisations, and there's the indicative cost, 1.4 million in the first year, 1.35 million recurrent, and obviously that's based on the January 21 costings and the workforce model we had in place in January 2021. Aligned to that, although not yet realised, is the potential future efficiencies. So that's very much based on how we operated the service in 2020 as such, but we are looking at a more integrated transport plan, low acuity transfer models, similar to we've done at Mid-Yorkshire. There's certainly more emphasis within clinical pathways and clinical navigators within our emergency operations centre and 111 to make sure that patients go to the right time, the right place. Much more emphasis on telephone triage. It's looking at the developments of pathways into specialist wards and units. Mark's already referenced the same day emergency care, the SDEC, which is available, which certainly has a great impact on ED avoidance and ED flow. It's about mental health pathways, and it's about making sure, from our perspective, that the category 3 and category 4 calls are directed to the right places first time. I think there's a more of an active role for our patient transport service. This is very much the emergency service focused, but it's not taking into account the efficiencies that can be provided by a patient transport service, because, like I've said, the step-down patients will be virtually all low acuity patients, not time-critical well patients, and they can be managed by our patient transport service safely and efficiently. I'm happy to take any questions.
Okay, thanks, Andy, for that. I'll open it up to questions then. Councillor Ramsey.
Thank you very much. Just a few questions from me about the modelling, if that's okay. I'm just trying to understand, when you say that 72 conveyances per day, I'm just trying to understand, is that based on an average, in which case, or
Yes.
Is that a yes?
Yes, it is an average.
Okay, all right. So you've used that then purely to get to a staffing model, have you? It's just that obviously an average is 50%, and so 50% of the time you might actually need to convey more. So I'm just trying to make that point. And then I just want to understand, if patients have been stepped down from Calderdale homes, so they've come into a Calderdale hospital, but they live in Calderdale, they're resident in Calderdale, they've been stepped down into Huddersfield. When they require then transport home, is there any additional workload there, or have you done some modelling to kind of offset it so that we understand that? I do think that we've already mentioned quite a few times about workforce in Scrutiny, and I'm aware that you've got gaps in vacancies at the moment, whether or not that you'll be able to. If this workforce modelling is right, this additional requirement is right, whether or not you'll actually be able to recruit to that. So I'm just trying to understand the model, and I'm trying to understand if even if you get the workforce model right, if you can actually recruit into it.
I'll try and answer all those questions if I can. Just remind me if I've missed anything out. So in terms of your first question, is that an average? Yes, it is an average. Obviously, the way that our service runs, just like the A&E department, it's based on seasonality. Generally speaking, Winter is our high pressure period, as you're aware. Summer is supposed to be our quiet period. That's certainly not been the case this year. But certainly from a high level operations point of view, what we've done is, this is a high level report, but ultimately those staff hours would be placed into rosters based on demands, so that we would place the staff at the right periods of time in order to be as efficient as possible and meet the demands within those services. What were the next question in terms of, was it in terms of staff, patients going home from the hospital?
Yeah, it was going from Huddersfield back to Calderdale residences. If they've been stepped down into Huddersfield beds, they are the patients that are most likely to require transport home, because of the nature of of them, I would imagine. So I'm just asking, have you modelled anything in regards to that as well?
No, that's not part of, we have not modelled that, primarily because that's not part of the A&E contract. That would be down to the patient transport contracts that are negotiated locally. So that's not part of this modelling. Was the next question in terms of workforce, how we would?
Yeah, it was, yeah.
Recruit to that. Yes, so yeah, I'd be quite confident we could recruit to those numbers. So we've got an excellent pipeline of recruitment of staff coming into the service. And we've also got excellent relationships with our partner universities for newly qualified paramedics. We've also got good links with NHS England to look at foreign paramedics. So we've just taken in up to 60 Australian and New Zealand paramedics that certainly come over for 3-4 years for experience. And they've been integrated very easily into our service because the paramedic degree is akin to ours. It's been developed on our systems. So from a clinical point of view, we've got a healthy recruitment pipeline, and we've got a very healthy paramedic pipeline coming into the system.
Thank you. Councillor Barnes.
Thank you, Chair. A couple of things. One, I think it's a comment that we mentioned earlier, and a lot of the whole of these plans of the reconfiguration are heavily reliant upon other areas within the health service, amending, changing, recruiting, and I think we as a committee should be, and as individual committees back in our own respective boroughs, need to be really 100% comfortable that these have been joined up. That one does not knock the whole tower over. And I think there are some concerns on that. And whilst it's good to hear that you have an active pipeline, as my colleague said here, there are some gaps at the moment. And we are all aware of recruitment, and we are aware of the issues in social care in terms of social care staffing now on a decline. Not in Calderdale. I don't know the answer for Kirklees, but I know in Calderdale that's not necessarily the case, but across the UK. So I think as a committee we need to really be looking at that going forward and making sure that those, and as individual committees. The second thing, I just wanted clarification on some of the numbers because I'm not sure I understand them. That we have 13 inter-facility transfers, which is a quarter of the number of patients conveyed, and yet actually takes 3 times the length of time. So we have 59 patients, which is an extra 10 hours and 39 minutes, but 13 inter-facility transfers, which is 29 hours and 57 minutes. Now, even my troubles on the 503 bus wouldn't have thought 13 journeys would last an extra 29 hours and 57 minutes. Though some nights I'm not so sure, last night being a prime example. So can I just get some clarification on the numbers? How come 13 inter-facility transfers, assuming that's between Calderdale and Kirklees, can add up to 29 extra hours a day?
Thank you. I'm just smiling because I seem to remember something similar in the Mid-Yorkshire reconfiguration when we were talking about timeframes from getting people to and from wards, etc., into other wards, etc., in another hospital. But Andy, you want to come in on those questions?
Yeah, I appreciate your question, and I'll try and answer it as best I can. I mean, I know there was no disrespect intended, but you mentioned there a bus service. It's not, obviously it's not a bus service. These are acutely ill patients that need transferring. So, and obviously that's governed by tightly measured mandatory response times for those patients. So this is about having available ambulances available to convey those patients, because those 13 interfacility transfers, it's not a case of it's one every hour. It'll be based on the demands within the department. So we know that the A&E department starts to get busy, as we do, from 10 o'clock, and that activity sort of builds and then sort of subsides from 11 o'clock-ish and gets quieter and quieter through the night. So we need to put more ambulances on during the day to meet that demand and less on an evening. So those 13 interfacility transfers, those hours have been increased by using an availability equation. So it's making sure you've got ambulances available to move those patients in a timely manner, to make sure that it's a safe conveyance and there's not inordinate delays within that department. And I hope that makes sense.
Yeah, I was just, the bus was meant to be very flippant, I think, as
yes.
there. It was just, obviously, I just wanted a greater understanding of how 13 adds to 30 and 59 only adds to 10. That was my point, because from what your answer there, early on you talked about averages, and now you're talking about specifics, because you were talking about it being needed during the day and night. So you're right, 13, isn't one every 2 hours, but that's the average that my colleague mentioned earlier. That 50% are going to be more than that, 50% are going to be less than that. So I just wanted to clarify on, and I think I would seek some more clarification on those numbers. Are absolutely spot on from the modelling. Thank you, Chair.
Well, from our point of view, they were verified by our business intelligence specialists and CHFT, so they were certainly as accurate as possible.
So basically what you're saying then, Andy, is it's about the availability of the transport of the ambulances to transport people across from one to the other. Is it also about the if they're ready on the ward to move, etc., when the ambulance gets there? Has that been modelled in, or is it just the ambulance time, hospital to hospital, that you've modelled?
It's the time that you mentioned there is included. So that that incident cycle, as we would call it, for interfacility transfer, that's based on historical data. So that would be based on when, because obviously we're doing transfers from Huddersfield to Calderdale all the time. So we know how long that takes from our historical data, and that's inclusive of the crew pulling up, walking up to the ward, moving the patient from the bed to the trolley, etc., and then doing the same at the other side. So it's all inclusive of that incident cycle.
Okay, thank you. Councillor Blackburn, did you no, Councillor? Yeah, Mark.
I think a couple of things in terms of that timing. I think I just recall the conversations we had with Andy and his BI colleagues. The time for 999 calls, the run time to the new emergency department, is purely based on travel time. Because everything else that happens to that patient for the time that the crew's with the patient at the scene, that's happening wherever they go. So it's purely looking at the travel time going to Calderdale rather than going to Huddersfield. For the interfacility transfers, that's new work, effectively, that's not happening. So all of the assessment at one side, making sure the patient's ready to go, getting them into the ambulance and getting them out of the ambulance in the right place at the time. So the whole job takes longer than just the
I think that answers my question, Chair.
That's
Thank
the question,
you, Mark.
yeah. And just in terms of the previous question about discharge home, I think because of the configuration of our services now, of those patients who need transport home, which are the more dependent patients, they're currently split between Huddersfield and Calderdale, but the patients are from Huddersfield and Calderdale, so they're still doing a lot of back and forth anyway. So in terms of the modelling, we haven't specifically looked at that, but we can do in terms of where they're going to go home to. But at the moment, there's a significant group of patients who currently live in Calderdale who are having a lift home from Huddersfield, and they will in future be at Calderdale having a lift home to Calderdale. So that's where we haven't gone into detail about those discharge transports.
Okay, thank you. Can I just ask a question about your impact on other hospitals, Andy, please? Because this was brought up on the Mid-Yorkshire reconfiguration as well, impact on other hospitals. And we've had this previously in business cases from CHFT as well, impact on other hospitals. So can I just check, so BRI, presumably that is, if that is the going to the nearest, then that's more likely to be the Calderdale side, if you see what I mean. Obviously, Calderdale is the transfers, but the conveyances into the acute facilities at Calderdale. And then the next impact is on Barnsley, and presumably that's from parts of Kirklees where that will be the highest. Yeah. Then Leeds General Infirmary, I am assuming that there will be transfers to Leeds General Infirmary, whatever the model, because of the tertiary services that there are, specialist services that there are at Leeds. So whatever model that is in there for your reconfiguration, there will always be movements into LGI and St James's. But the next one down is Pinderfields and the impact on Pinderfields. Now we already have impacts on Pinderfields, and we already have in North Kirklees, we have people who don't necessarily go to Pinderfields, do we? We have I think BRI is also used for people in Kirklees sometimes as well. Anecdotally, that's what I understand. So when we're talking about the impacts on these other hospitals, has the impact on the other hospitals been fully discussed with these hospitals? Do they have the capacity to be able to take this impact? And how, and this really would have been a question for the ICB as well. How are they modelling that impact across West Yorkshire? Okay, so I'm not sure whether that's for Andy or for the CHFT, but whoever wants to go. Thank you.
So the first part of answering that question is we have had dialogue with all the trusts impacted from this modelling. They have full awareness of those impacts. If you look down the impacts, you're looking at the largest impact at Barnsley of potentially 4 additional attendances per day. I think that's viewed as a moderate impact. It will need more detailed modelling as we approach implementation around capacity. Commissioning partners in both places are well aware of this modelling. They have confirmed broad affordability both on the impact on ambulance services, but also on the need for understanding funding flows as they may impact to meet additional demands in neighbouring hospitals. I think more detailed questions, notwithstanding Mark might have some additional detail. I did speak with place-based commissioning leads yesterday. They were happy to provide additional information, just couldn't attend today.
Andy, did you want to come back at all on any of that?
No, I mean, I think it's that information that we provided. Like I said, it's heavily caveated. Yeah. I appreciate the patient flow across the system is much more complex than we've prescripted here, but it is indicative, and it seems right. It does feel right to me, and I think it's not for Yorkshire Ombuds to share that. I think it's right for CHFT to have those discussions as Anne's described.
Yeah, and can I just clarify that when you're saying you need the capacity that you need in the system, that is that dependent on do you still call them handover and turnaround times? Is that dependent on handover and turnaround times, certain times being met, so that there is not a delay in the system? Would you need extra capacity if those trusts were not meeting the handover and turnaround times? Thank you.
From a transformation and reconfiguration point of view, we've used historical times. So we've used the handover times and the turnaround times of the ambulances that we've that we experienced during that data search that we did during 2019. So classically, we do not get any chronic handover delays within West Yorkshire. We have extremely lucky. We don't have the South Yorkshire problems and the problems that we have in North and East of the patch, where they do have chronic problems. So to answer your question, would it impact on the incident cycle? Would we need more resources? Yes, we would. Would that be as a result of the reconfiguration? Probably not. That's usually a result of external pressures, winter pressures. That's certainly my experience within the West Yorkshire health system.
Okay, thank you. Councillor Hutchinson, you want to come in?
I think you've asked the question I wanted to. That I wanted to know was that we hear a lot of reports of other ambulance trusts struggling because of ambulances backed up outside accident and emergency departments. I'm pleasantly surprised to hear that that is not a problem in West Yorkshire, and long may it stay that way. Have I got that correct?
That's totally correct. Yeah, I'm not saying we don't have as issues, but there tend to be peaks and troughs. It's not a chronic problem, touch wood, and like you say, long may that continue.
Councillor Luke.
Thank you, Chair. Hi, Andy. Thanks for your presentation. I was just wondering, what proportion of calculated journey times were you able to do with reference to the real historical data versus AA route planner? And just more broadly relating to that, if you had to put a percentage on how confident you are that 3 double crewed ambulances will be enough to cover this, what would you say that is? Thank you.
I would, looking just from when we did this and our discussions with Mark and CHFT colleagues around BI, the majority of the data was historical data. So very little had to be pulled from the AA route planner. What perhaps some of the journey times that we were missing was when an ambulance returned to base after it had conveyed their patient to an ED site. So we used AA route planner for that, but majority information was taken from historical records. In terms of the study, I'd be quite comfortable based on the demands in 2021 when this 2019 base for 2020. I'd be quite happy that that model would be sufficient. Will things change within the next 3 or 4 years before we go to full reconfiguration? Yes, it will. This modelling will have to be refreshed and redone, just in the lessons learned from the pandemic. As I've mentioned, the efficiencies within the system, the changes within our workforce, and the shifts in demand that we're seeing. We tend to move. It's not tending to be in seasons anymore. It tends to be constant. So it would certainly need reviewing. But in terms of the modelling, I'm fairly confident it feels a safe level of service for me. And I think that's one of the lessons we took from Mid Yorkshire. This was not about getting it absolutely right, because it's an hypothetical situation. This is about understanding the risks, developing a mitigation plan that provides a safe level of service for patients, and then re-evaluating constantly as soon as a reconfiguration comes into place to make sure that you've got it right, and then having the flexibility to either add or remove or change the time frame of your resources to make sure that you have got it right.
Thank you. And thanks for that, Andy. So what I'm kind of getting from what you're saying is you wouldn't be too surprised if 3 didn't turn out to be enough, considering all the unknowns involved. Is that what I'm getting?
I think it's unfair to say that, because, like I said, there's a lot of efficiencies to be had that have not really been realised within this model, that are probably going to be developed in the next 2 to 3 years in terms of our workforce. A lot of health services are moving to a similar reconfiguration. There's much more emphasis on low acuity transport, which then releases the qualified ambulances to go to the category 1, category 2 patients. So I think there will be a lot of efficiencies. So who knows? I'm pretty sure that 3 ambulances will be there or thereabouts in two or 3 years' time. I don't think it'd be too far off the mark.
Thank you.
Councillor Ramsey.
Thank you very much. So I appreciate your papers really around resources, but I'd feel as though I hadn't asked something about clinical quality if we didn't go down this one. So we've got 59 patients conveyed per day, and I did a quick calculation on my phone to work out that they would be 11 minutes extra in an ambulance on average. So I'm working on averages. Just reassure us that that additional 11 minutes does not put patients at risk. I understand that you're very expert within there, but then, you know, I'm just trying to get a feel of that additional 11 minutes for those patients, what impact that has.
It's extremely hard to answer that question, isn't it? Because I mean, there's such a myriad of patient conditions, and where they are within that cycle of being well and extremely poorly. All I can refer you to the fact is that our workforce model now is starting to include, you know, level 7 critical care paramedics, level 7 specialist urgent care paramedics. There's certainly increases within technology, vehicle design, monitoring, telemetry, that all will assist the paramedic to make sure that those 11 minutes, I know what you're saying, it's an average, it's an arbitrary 11 minutes, but they will be as safe as possible. But there will be patients that are extremely critical ill, but they've been transferred to a patient centre that is, you know, is consultant led, and they've got state-of-the-art facilities, which Mark has described. So it gives them a very excellent, you know, chance of survival.
Yeah, thanks for that. I suppose I am thinking about that small minority of people that would go immediately to resource. So I'm just trying to get a feel of that 11 minutes and the impact on that. But I understand what you're saying, so I don't know.
Yeah, Mark, did you want to come in on that?
Yeah, I think it's always difficult, isn't it? Because we talk about the most seriously ill, and those are the people who I think have got the most to gain from going to a service that can cater for all of their needs. Whereas at the moment, they're going to a service which we hope will cater for their needs, but doesn't always, because half of our services are on the other side. So there's a balance between how far do we need to go to get to the right place rather to where we hope is the right place. So if you think about the most critically injured people in Huddersfield and Halifax and all across West Yorkshire, don't go to Calderdale or Huddersfield or Bradford, they go all the way to Leeds, because we know that the evidence says that they're better off going there as a group. And that's pretty much what we're trying to do here. We're trying to put all of our acute services where all of our sickest patients will be. And I think, although we talk about getting people into resus to see me, there's very few occasions where what I do in the first 10 minutes, there's a big difference that Andy's sort of top-end paramedics haven't already done. So with the paramedic service that we've got in the UK, we're very lucky because we've effectively taken the resus room to the patient. And I think those benefits from getting the people to the right place far outweigh any risks.
Okay, thank you. No more questions then. Thank you for that, Andy. Councillor Munro, did you have any points you wanted to raise, or are you okay? You're on mute, Councillor Munro.
Thank you for asking me. I'm okay. I've been listening to to what's been said. It's really interesting. Thank you.
Okay, thank you. Right then. So if we move then to the next agenda item then, which is the next steps. Okay, so I think we talked in that previous discussion, we talked about the impact on other trusts for the ambulance movements to other trusts, didn't we? And you were saying that that is part of conversations that are ongoing, and that the ICB also, you've been talking to them. Did I get that right? You've been talking to them about that, because is it the ICB that still? It was the CCGs that commissioned ambulance service. Is it now? It's now the ICB that commissions it. It's not the individual trusts that commission it. Yeah. So right. Okay. So we need. That modelling presumably will be part of your full business case as well. Okay, so we talked about workforce model. Does the panel want to see that workforce model as soon as it's available, rather than waiting for full business case clearance? We would like to see that workforce model in detail as soon as it's available. Yes? Okay. The communication strategy, we talked about that. I think we'd like to see that well before it's to be utilised, so that we can go through that. Yes, bearing in mind it has started already, yes. But I think that's, the more detailed bit about the changes, etc. When we would like to see that well before. Yeah, okay. We also talked about the capacity in the system. We've had the recommendation about the individual scrutiny panels taking on and reporting back as far as out-of-hospital services are concerned. But we also have capacity in hospital and the bed capacity that is reasonable for the model and the population requirements moving forward. Bear in mind Councillor Hutchinson's point about more beds being needed in the system overall. Councillor Hutchinson, did you want to come in?
Yeah, I mean, I see this as being the crucial stage if we are going to be able to reassure the Secretary of State as to the so 2 out of the 3 issues that the IRP wanted resolved, and without bringing that information gathered at the different boroughs' scrutiny committees, but back here for consideration, so that we can know that we can positively recommend what's going on, or if we have concerns that we can raise those with the Secretary of State at that time. But I think this is really something that we need to progress very, very quickly.
Thank you. And we also, last time we discussed about travel plan as well. So I think we'd like to see that sooner rather than later as well, the travel plan. And the capital financing, we've talked about that, and we've said we would like to see that after your November review. We would like an update on that after your November review, bearing in mind that you have your procurement stages as well as you move forward. Okay. Is that generally, Councillor Hutchinson?
There was, we've been told the benefits of this project, of the reconfiguration, but there are always risks involved with any project, and those, we haven't seen any assessment of the risks and how those are being mitigated. So I do think from a balanced point of view, we need to see both sides.
Okay, thank you. Would the panel, if we need to look at dates, and we need to obviously for meetings, and we need to also discuss with CHFT and ICB colleagues about dates. But a suggestion maybe would be looking in early in the new year, certainly for the outstanding items like the travel plan and things like this. Okay. Yes,
I think it is important that the ICB attend the next meeting. I think I'd like to put that on record that, I hear they weren't invited, but I don't know when they were invited in terms of how long, but I think it's vital that they attend the next meeting.
Yeah, I think so. And bearing in mind that we can do things in a hybrid way these days. So if they haven't got time to travel, they can come in online, as Andy has done. Mike?
Just to suggest that we've had useful meetings with the joint chairs and Anna and colleagues, and perhaps we need another planning meeting to do that, but also to invite the ICB to that planning meeting, and do that well in November, I would suggest.
So would the committee be comfortable with the joint chairs having a planning meeting with CHFT and the ICB colleagues to move this forward? And then we would like the full business case for the whole reconfiguration, I think. I think that is a key for us all, that we would like that. So we would like discussions on how we can do that, bearing in mind your commercial confidentiality, etc. If you could have discussions with the necessary people on that, and then at the planning meeting we can discuss how we're going to do that, and we can work out how the committee can look at how the committee can have input into the full business cases, keeping your commercial confidentiality. All right, okay. Councillor Brown.
Thank you, Chair. Can I make a suggestion about that? That actually, perhaps the full business case, it's a paper document that's brought to perhaps a closed meeting, not open to the public, but equally you take those papers back from us after, so we're not taking any information away, and that might be a solution. Thank you, Chair.
I think we'll have a chat about how we do it. Okay. All right. Also the committee, we would reserve the right to contact the Secretary of State after we've seen that full business case with our comments on the reconfiguration, or even before if we wanted to. But I think we need to see that full business case to get the whole picture, don't we? To write to the Secretary of State with our comments, both positive or negative, or any concerns that we have. Yes? Yeah? Okay. All right. Thank you ever so much, everybody, for your time this afternoon. We will close the meeting there. Thank you.